So my name's Nuru Noor. I'm a clinical lecturer in gastroenterology based in Cambridge in the UK, and I'm delighted to chair this webinar today. We have two excellent speakers lined up for you, and the key thing is we want to make this webinar as interactive as possible. So please do send in your questions throughout this evening, and we'll pose those questions to the speakers. You can see the agenda highlighted here, and as I say, we have Professor Afzali, who'll be our first speaker, and then Professor Moran, who'll be our second speaker, and we'll have plenty of time for Q&A to pose your questions to the speakers. These are the disclosures for both the speakers and for myself as the chair. And I'll just introduce Professor Afzali before I hand the floor over. So Professor Anita Afzali is the James F. Heddy Endowed Chair, Professor of Medicine, and she's a gastroenterologist specializing in IBD, as well as being a physician executive leader. She's recently transitioned to the University of Cincinnati after successfully building the first standalone multidisciplinary IBD center and serving as the medical director at the Ohio State University Wexner Medical Center for the past 5 years. Professor Afzali currently serves as the Executive Vice Chair of the Department of Internal Medicine at the University of Cincinnati and is Associate Chief Medical Officer of UC Health Systems. Her areas of research include clinical outcomes and clinical trials of novel therapies and diagnostics in IBD. We're really looking forward to her talk today, and Professor Afzali, the floor is yours.
Excellent. Thank you so much, Dr. Noor, and thank you for the inviters of this entire conference, and thank you all for joining us today. I'm really pleased to be here with my friends and colleagues. And so what I've been asked to do is to present on isolated proctitis and really provide and help set the stage for my colleague to also further enhance this conversation. But as Dr. New mentioned, we really want this to be very interactive. So please, we encourage you to put in your questions and let's allow for a dialogue. What I'd like to cover in primary 3 objectives is to, first of all, be able to define isolated proctitis and also its associated symptoms. I then want us to review the prevalence of isolated proctitis, as well as review challenges when we're dealing and managing patients who suffer from this disease. So as a way of a background, I'd like to first start with just defining what isolated proctitis is. And really this definition, I think it's very important for us to see this. And then as we talk about how to manage it, you'll see how certainly we cannot associate the disease location with disease severity. But as a way of a background, let's take a look at isolated proctitis. And by definition, that means that the inflammation is limited to the rectum alone. Then we have left-sided colitis, and here the inflammation is in a continuous form from the rectum up to the splenic flexure, and then extensive colitis as defined by inflammation that truly extends proximally or beyond the splenic flexure. When we talk about and when we're trying to understand the epidemiology of isolated proctitis, you'll see that around 30% of our patients, and I'm sure you experience this in your clinic as well, who have an isolated proctitis or isolated form of the disease that is limited to the rectum. And again, by definition, really highlighting that this is where the inflammation involves the dentate line, and once again, it's confined to the rectum alone. So the proximal mucosa appears normal. Now, certainly when we have a patient who suffers from isolated proctitis, there can be a variety of a presentation of symptoms. And sometimes, as you probably know, the symptoms can interact with and you can associate it with other disease states or even conditions. Some of these symptoms, such as rectal bleeding or tenesmus or urgency, are definitely ones that are frequently reported. Fecal leakage, as well as even incontinence, has been reported, and it can be unfortunately experienced by our patients. And overall, I think we forget the impact it has on the quality of life for our patients. So certainly when we're talking and throughout this webinar, I want us to be mindful on the impact that it has on our patients, on their day-to-day function and quality of life. Now, when we talk about the risk for progression of proctitis, there's a couple different ways to look at this in the sense of how they're initially presenting, but then also what's happening over time despite their initial presentation. So, an inception cohort study of about 1,000 patients with ulcerative colitis was examined, and really the analysis was to observe and review the subgroup of the patients, about 460 patients, who were diagnosed during a time period and evaluate that risk of proximal progression. So, that risk of proximal progression, the 5 year probability was about 27%. Over 10 years, it was about 40%. And at 25 years, over half, so 50% of these patients had a progression of their disease. 340 patients with an original diagnosis of ulcerative proctitis who was also seen at different institutions. And again, during a time period when another study, this was a multi-center study, also evaluated very similar question in the sense of what's the risk of progression from isolated proctitis to more progressive disease or proximal progression. And again, here the 5 year probability in this study, a multi-center study, was about 8%, but then 10 year overall, 30%. So, all in all, both of these studies looking long term among patients who suffer with ulcerative colitis, where they initially had isolated proctitis, you can see that 5, 10, and even 25 year period over time, there is absolutely a risk of disease progression and a risk of inflammation continuing to advance beyond that rectum. So, again, we have to be mindful of this because as we see and diagnose this disease state for our patients, we have to be mindful of the fact that they are, in fact, at risk of a progression of their disease. When we talk about isolated proctitis, I think all in all, when we see this during colonoscopy or sigmoidoscopy or for evaluation, we absolutely still need to have a differential diagnosis. Not everything is inflammatory bowel disease, and certainly we need to have that differential diagnosis to appropriately see what else could this be. Infections, and as an example, gonorrhea or chlamydia can absolutely cause proctitis, and so we need to be mindful of that as far as an STD. Hemorrhoidal bleeding, some of the symptoms I described to you, the rectal bleeding, fecal urgency, tenesmus, it could be associated with hemorrhoids. Certainly, malignancy is in the differential. And then in the appropriate patient, radiation proctitis or even diversion proctitis, these also need to be included in our differential when we're evaluating a patient who presents with the symptoms I described earlier.